All right,
What?
we are back. This is Senate Health and Welfare on March 16th, and we are looking at H 655, which is on the floor, I guess, in the House, and it will be coming to us at the end of the week, so that would be good. So Jennifer Kirby, thank you for being here.
Thank you. Good morning. Jen Carvey from the Office of Legislative Counsel. We are looking at H 655, an act relating to establishing a telehealth licensure and registration system. And as the chair said, this is currently on the floor in the House. Second reading was yesterday, and it's up for third reading this afternoon. There are two documents. We're going to mostly be working off of the House Healthcare recommendation. It's draft 3.2, and it's a strike all amendment, but there are also some elements from the Ways and Means Amendment that I will try to kind of incorporate as we get to those parts of the bill. So this is adding a new chapter in Title 26, which is where we do the professional regulation, most of the professional regulation. And Chapter 56 would be called Telehealth Licensure and Registration for Out-of-State Healthcare Professionals. It starts out with the scope, and it specifies that it applies to certain healthcare professions regulated first by OPR. And there's a long list. I don't know if you want to go through what all of these are now, or if you, I don't know how deep of a walkthrough you want to do. So I guess I would ask.
Okay,
Do you want me to go through what all of the professions are here?
No.
Okay, it's a long list of healthcare related professions regulated by the Office of Professional Regulation, OPR, as well as on the bottom of page 2, the certain healthcare professions regulated by the Board of Medical Practice, those being physicians, physician assistants, and podiatrists. Then we have a list of definitions starting on page 3. Some of these are pretty straightforward. Board is the Board of Medical Practice. Healthcare professional is someone who holds a valid license, certificate, or registration to provide healthcare services in any other U.S. jurisdiction, and a healthcare profession that is one of those listed in section 3051. So that long list for OPR, shorter list for Board of Medical Practice. Definition of healthcare services, our fairly standard definition. In good standing, which comes up later in the bill, means that a healthcare professional holds an active license, certificate, or registration from another U.S. jurisdiction. They're not subject to a disciplinary order that conditions, suspends, or otherwise restricts their practice in any other U.S. jurisdiction. And they are not affirmatively barred from practice in Vermont for any reason, including reasons of fraud or abuse, patient care, or public safety. Mandatory disclosure, which you'll see come up later, is certain information that the healthcare professional must disclose to the patient at the initial telehealth visit or consultation, as determined by the relevant regulatory body by rule. Office is OPR, the Office of Professional Regulation. And then I've incorporated definitions from the insurance statutes of store and forward, telehealth, and telemedicine. Store and forward and telemedicine, and we've defined telehealth for purposes of this chapter as healthcare services delivered by telemedicine, so that's why that definition is there, store and forward, or audio only telephone. So that's the scope of services for which we are doing the licensure and registration in this bill.
This is very helpful to have those definitions in front of us at all times.
Great, yeah, that was more helpful to have them here than just referring you to health insurance statutes.
Yes.
All right, so then we have in section 3053 that a healthcare professional who is not otherwise licensed, certified, or registered to practice in Vermont, but is licensed, certified, or registered in good standing in all other U.S. jurisdictions where they are or have been licensed, certified, or registered, and who wants to provide healthcare services to a patient or client located in Vermont using telehealth, they must obtain a telehealth license or telehealth registration from OPR or the Board of Medical Practice, as set forth in this chapter. It says that a telehealth license or registration issued pursuant to this chapter authorizes the healthcare professional to provide services to a patient or client located in Vermont using telehealth only, and it does not authorize the person to open an office in Vermont or to provide in-person services to patients or clients located in Vermont. So if you want a telehealth license or registration, that's what it lets you do. It doesn't open the door to other things. You still have to get a full license for that.
Question, what if you're, do you mind if I
Yeah, no, go ahead.
if you're an in-person provider in Vermont, do you also have to get the telehealth license? Okay.
No, and I would welcome Lauren to chime in anytime I get something wrong, but no, you don't. The full license covers telehealth and in person. The telehealth just covers telehealth. All right, and then it also says a healthcare professional who is not otherwise licensed, certified, or registered to practice in Vermont and provides healthcare services in Vermont using telehealth without a telehealth registration or license, or provide services beyond the limitations of the telehealth registration or license, is engaged in unauthorized practice as defined in the relevant OPR and Board of Medical Practice statutes and is subject to the penalties set forth in those sections. So kind of coming at it from the other side, if you go beyond what your telehealth license or registration says you can do, that's unauthorized practice, and we have laws on that. Then we have the scope of the telehealth license and telehealth registration. So for the license, a healthcare professional who, again, is not otherwise licensed, certified, or registered to practice here, because if they are, they don't have to get the telehealth license, may obtain a telehealth license to provide healthcare services using telehealth to a total of not more than 20 unique patients or clients located in Vermont during the 2-year license term. So not more than 20 different patients during the 2-year license term. To be eligible to get a telehealth license under this chapter, a healthcare professional must complete an application in a format and with such content as prescribed by OPR or board. They must hold an active, unencumbered license, certificate, or registration in good standing in any other U.S. jurisdiction to practice the healthcare profession that they're looking to practice in Vermont using telehealth, and provide verification of their license, certificate, or registration to OPR or the board if required by the profession. If required by rules adopted by OPR or the board under a later section, they must submit a copy of a mandatory disclosure that conforms to the requirements established by rule. If required by the rules adopted by OPR or the board, they must provide documentation of professional liability coverage or financial responsibility that includes coverage or financial responsibility for services provided by telehealth to patients or clients not located in their home state in an amount established by rule. Was that a question?
No, I'm saving it for more and I'm good.
Great. And they must provide any other information and documentation of qualifications as required by rule, and pay the required telehealth licensure fee. And then this is where we change things from the OPR. Oh, no, I'm sorry. Actually, I guess we are good on the, it's just the registration changes. So pay the required telehealth license fee, which is 75% of the renewal fee for the profession. A healthcare professional may renew a telehealth license every 2 years upon application and payment of the required fee. So this one is renewable. They can maintain it on an ongoing basis, but again, for up to 20 patients during that 2-year term. A license that is expired would be reinstated upon payment of the biennial renewal fee and the late renewal penalty, which would be 75% of the regular late renewal penalty for their license. So that's the license. Then we get to telehealth registration. And this would allow a healthcare professional who is not, again, otherwise licensed, certified, or registered to practice in Vermont to obtain a telehealth registration to provide healthcare services using telehealth for a period of not more than 120 consecutive days from the date the registration was issued, and to a total of not more than 10 unique patients or clients over that 120-day period that the registration is in effect. To be eligible to obtain a telehealth registration, the healthcare professional must complete an application in a format with such content as prescribed by OPR or the board, hold an active unencumbered license, certificate, or registration in good standing in any other U.S. jurisdiction to practice the healthcare profession that they seek to practice in Vermont using telehealth, and provide verification to OPR or the board if required by the profession. If required by the rules adopted by OPR or the board, submit a copy of a mandatory disclosure conforming to the requirements established by rule, and pay the required telehealth registration fee. Here's where we change. And now we go to the, if you want to, otherwise I'll just tell you what it says. The Ways and Means Amendment would change instead of what the House Healthcare recommended, which is 50% of the renewal fee for the profession. It would instead be the required telehealth registration fee would be the lesser of 50% of the renewal fee for the profession, or the application fee for a full license for the profession as set forth in rule. So the renewal fees are higher than the application fees. So if the renewal, if 50% of the renewal fee is more than what the application fee would be, then they would pay the application fee. So it's the lesser of those two.
That's an amendment that's on the floor that we'll see when the bill gets over to.
Right, when you, assuming it, right, it was adopted yesterday, both the Ways and Means Amendment and the House Healthcare proposal were adopted yesterday. Assuming there are no other changes to the floor, you'll just see them incorporated, all these changes incorporated into what you'll see when we go through it, when you have it in your possession. Okay, on the top of page 9, a healthcare professional may only reactivate a telehealth registration once every 3 years. So unlike the license that can be renewed on an ongoing basis every 2 years, for the telehealth registration, it's 120 days, not more than once every 3 years. And a telehealth registration shall not be renewed or reactivated upon expiration.
It's a semester.
Yes, I mean, it's right.
Students.
Approximately 4 months, right?
Yeah, okay.
And then it says that a healthcare professional seeking to provide healthcare services to a patient or client located in Vermont using telehealth also has the option to register or apply for a full license to practice the profession in the state in accordance with the applicable provisions of law. Nothing in this section should be construed to prohibit someone who is qualified from registering or obtaining a full license to practice in Vermont. So this is just another option if they want to only do telehealth and for a limited panel of patients, they can always apply for a full license. And then the next change that Ways and Means proposed and that the House has adopted is some fee credit. So if a healthcare professional who has a telehealth registration issued under this chapter chooses to apply for a telehealth license, so kind of the next step up, or a full license, while their telehealth registration is in effect, or within 3 years following the effective date of their telehealth registration, then the amount of the fee that they paid for the telehealth registration would be credited and applied toward the relevant telehealth license or full license. So they could apply that full amount that they paid toward going for the next level or the full license.
Where is that language?
This is in the Ways and Means Amendment.
Oh, okay, because I said, wait, this isn't here. Okay.
And similarly, if a healthcare professional who holds a telehealth license chooses to apply for a full license while their telehealth license is in effect, so during the 2 years that their telehealth license is in effect, the amount of the fee that they paid for the telehealth license would be credited and applied towards the application fee for the full license.
Can I ask a question?
Yeah.
So for the first one, what was the logic behind the 3 years after? So if their licensure has expired, they still have 3 years that they can credit it?
That was a decision from the Ways and Means Committee, so you may want to hear from the reporter.
Well, yeah, we'll have to hear about that.
It's a lot.
All right, back to the House Healthcare Amendment. As far as scope of practice and standard of practice, in order to be eligible for a telehealth license or registration, the healthcare professional, as we've mentioned, must hold a license, certificate, or registration in another U.S. jurisdiction, and then this specifies that it must authorize the provider to engage in the same or broader scope of practice as healthcare professionals in the same field are authorized to engage pursuant to a license, certificate, or registration issued in accordance with the relevant provisions of this title. So we're trying to do kind of apples to apples coming in to practice telehealth in Vermont. And while practicing in Vermont using telehealth, a healthcare professional holding a telehealth license or registration must practice within the scope of practice established in this title for that profession and practice in a manner consistent with the prevailing and acceptable professional standard of practice for a healthcare professional who is licensed, certified, or registered in Vermont to provide in-person healthcare services in that profession. Section 3056 says that a healthcare professional who holds a telehealth license or registration under this chapter must document in the patient's or client's medical record the healthcare services that they delivered using telehealth in accordance with the same standard used for in-person services and comply with the requirements of our laws on healthcare providers delivering services using telemedicine, store and forward, and audio only. That's what's in 18 USA 93, 61, and 62, to the extent applicable to the profession. And records, including video, audio, electronic, or other records generated as a result of delivering healthcare services using telehealth, are subject to all federal and Vermont laws regarding protected health information. In section 3057, it talks about the effect of disciplinary action on the out-of-state underlying license. So a healthcare professional shall not obtain a telehealth license or registration under this chapter if their license, certificate, or registration to provide healthcare services has been revoked or is subject to a pending disciplinary investigation or action in any other U.S. jurisdiction. And it would require a healthcare professional holding a telehealth license or registration under this chapter to notify OPR or the board, as applicable, within 5 business days following a disciplinary action that places a warning, reprimand, condition, restriction, suspension, or any other disciplinary action on their license, certificate, or registration in any other U.S. jurisdiction, or of any other disciplinary action taken or pending against them in any other U.S. jurisdiction. Section 3058 says that a healthcare professional holding a telehealth license or telehealth registration is subject to the laws and jurisdiction of the state of Vermont, including those provisions regarding healthcare professionals using telemedicine, store and forward, and audio only, and laws regarding prescribing, health information sharing, informed consent, supervision and collaboration requirements, and unprofessional conduct. 3059 has exemptions from the registration and licensure requirements. A healthcare professional is not required to obtain a telehealth registration or licensure solely to provide consultation services to another healthcare professional regarding care for a patient or client in Vermont, as long as the consulting healthcare professional holds a license, certificate, or registration to practice the profession in 1 or more U.S. jurisdictions, and the consultation is based on a review of records without in-person or remote contact between the consulting healthcare professional and the patient or client.
Go ahead.
3060 specifies that venue for any civil action initiated by OPR, the Board of Medical Practice, or a patient or client who has received telehealth services in Vermont from an out-of-state provider holding a telehealth license or registration is in the patient's or client's county of residence or here in Washington County. 3061 allows OPR.
So when you say county of residence and patient, that means, that could mean the temporary residence in the state. I'm trying to sort out what that means, but I'll ask that question another time.
I'm gonna make that a warrant question.
Good problem.
3061 allows OPR and the board to adopt rules to carry out the purpose of the chapter, including in consultation with the appropriate boards and advisor appointees for OPR regulated professions, rules regarding any profession-specific requirements related to telehealth licenses and telehealth registration. Section 2 is a little bit different. Section 2 is actually provisional licensure for all OPR professions, not just the healthcare professions. And this section would allow the director of OPR to issue a 90-day provisional license to an individual who has completed an application for full licensure. And one of the following circumstances applies. Their eligibility for licensure is contingent upon acceptable verification of licensure from another jurisdiction. So OPR is waiting on verification from another jurisdiction, or their eligibility is contingent upon completion of a background check, or if they are an active duty member of the U.S. Armed Forces who's assigned to duty in Vermont, or that person's spouse. It says that a provisional license is based on a voluntary agreement between the applicant and OPR to expedite the applicant's entry into the workforce in which the applicant agrees to forego the procedural rights associated with traditional licensure in exchange for a provisional license pending final determination of the license application. A provisional license can only be issued to an applicant who can attest to material facts consistent with the requirements of full licensure, including their standing in other U.S. jurisdictions, their criminal history, and their disciplinary history. An individual to whom a provisional license is issued must expressly agree that OPR may summarily withdraw the provisional license upon discovery of any inconsistency or inaccuracy in the application materials. It says that someone who is aggrieved by a denial or summary withdrawal of a provisional license issued under this section has as their exclusive remedy the right to have their application for conventional licensure determined in accordance with the usual process. It allows the director to extend a provisional license beyond the initial 90-day period if the reason for issuing the provisional license in those A, 1, 2, and 3 has not been resolved.
These are just regular provisional licenses, not telehealth provisional licenses? Okay. So this was essentially a vehicle to get this in there because it's a licensure bill, or how is this related?
I would defer to
Lauren. Okay.
Section 3, there's actually a new section 3 from the Ways and Means Committee, and this is an appropriation of $360,000 to OPR and FY23 to develop and implement the telehealth licensure and registration system established in this act, and no one has a fiscal note. And then they renumbered the effective date section, and so for the effective dates, the section on licensure and telehealth licensure and registration takes effect July 1st, 2023. If you remember, in H654, you created a sort of short-term telehealth registration to go until July 1st, 2023, except that OPR and the board have to begin the rulemaking process prior to that date, so their rules are ready to go on July 1st, 2023. Section 2, the OPR provisional licensure and the effective dates take effect on passage, and Section 3 on the appropriation takes effect on July 1st, 2022, because it's an FY23 appropriation. And House Healthcare would change the title to reflect both provisions of the bill: an act related to telehealth licensure and registration, and to provisional licensure for professions regulated by the Office of Professional Regulation.
Wow. Good. I have some questions, and that's probably our Lauren questions.
Okay.
But the one question I do, I'll wait. Question for Jack.
And then do you call the next door?
You're not going anywhere, right? So
Going over
you're
there.
going over there. So that's good. Okay, so why don't we have Lauren come up and, I know you have testimony here, but would you mind if we asked you some questions before that? And if you say it's in my testimony? Good. Okay. So the question I had while we were listening is, there's, for example, on page 10, number 2, there's comments about the patient. We just go to it. Number 2, practice in a manner consistent with prevailing acceptable professional standards. So what kind of oversight is there? Is this a complaint-driven oversight? Okay. And so
For the record, Lauren Hibbert, Director of the Office of Professional Regulation. And yes, a lot of our oversight will be complaint-driven, but a crucial part of this bill is rulemaking authority. So we will be creating rules for each of the professions that we oversee, and the Board of Medical Practice is going to complete rules related to telehealth for their professions. And those rules will outline, profession by profession, specific requirements for providing telehealth, resources for out-of-state professionals that they'll have to follow, really obvious ones, our prescription monitoring program, but also something I've been very concerned about with telehealth is connection to our emergency mental health services. Vermont has a unique system for emergency mental health services. I want to make sure that someone who's receiving any type of telehealth, it doesn't have to just be mental health. It could be primary care, it could be specialty care, from someone in Nebraska, that person knows how to connect them to emergency services if needed.
Okay, that's helpful. And that'll be integrated into the rules.
Yes.
Then I do have another question. As you went through the bill in the House, was there any discussion about, now we're gonna have people coming into the state, out of state, and have up to 20 patients, for example. Was there any discussion about advertising? Is there a rule against advertising? How do these people get connected? The assumption is it's, the student coming from California wanting to stay in contact with their professional, but.
So I don't think this bill certainly has no restrictions or limitations on advertising. And I think one of the groups that will be benefited through the implementation of this bill will be the student who's coming to the state, or the person who's relocating to Vermont, the person who's seeking a second opinion. That's clearly true.
Yeah.
But there's also some larger healthcare models that have really grown during COVID in ways and means. I talked about very personal example. At the beginning of COVID, I spent 1,000 hours looking into Zoom. And I thought to myself, I'm looking very old and I need to do something about my wrinkles. So I went and I used a telehealth medicine company. Essentially, they took a picture of my face that I gave them over the phone through Store and Forward. And somebody prescribed me some prescription cream. I subscribed to the service for an embarrassingly long time. I've not canceled it. But that is telemedicine.
Right.
And they were advertising to me when I said, what does a 44-year-old woman do about her skin? And so I know that this is happening. You've seen probably mental health apps doing this as well. Advertising to Vermonters. If you listen to any podcast, you've heard about better health and mental health, and there's a lot of them out there. So there's no restriction in this bill about advertising, and no constraints.
No permission and no restriction.
That's correct.
That's still just the way it's been.
Yep. And it's possible that maybe we would have that authority under rulemaking. I would have to really think about whether that would be an abuse of our rulemaking authority. I haven't thought about that.
I know, because one of the traditions in the medical world is they don't advertise. It's word of mouth and referrals and so on. So it's something to think about going forward. I can think of the good things, and I can also think of the negatives. So.
Yes.
Okay. What I did have. Oh, I did have another question. So did we ever pass we passed the nurse compact?
Yes.
Is there some relationship here? If you have a compact license, then?
Yes, so I'm sitting in this chair representing myself as the director of the Office of Professional Regulation, but also the facilitator of the Act 21 working group, which I did testify to this committee in that joint session at the very beginning of the legislature that you had with healthcare. We convened a working group of about 60 stakeholders, had multiple meetings plus breakout groups over the course of multiple months, and published the report, which I do believe is posted on your website. And that working group really looked at compacts. Compacts are the best solution to telehealth out there, because a compact nurse who provides telehealth and holds a license in Nebraska, which is I'm going back to Nebraska, I don't know why.
Don't go back to Nebraska, stay here.
I've spent a lot of time on the highway in Nebraska, but otherwise no time. So a compact nurse from Nebraska who's providing telehealth here would not have to get a telehealth license under this bill, and has the authority to practice telehealth now. We did implement the nurse licensure compact. February 1st was its first date, and last time I checked, we had over 1,000 compact licenses in our state.
That's amazing.
It is amazing.
Since February 1st.
Yes.
Wow.
Yeah, so we need to talk about that another time. We'll come back to that.
Okay.
Lots of questions there, but thank you for answering that. So in a way, I mean, this could almost be a transition. If all of these professions were compact professions, but we won't go there.
Possibly, if all of these professions were compact professions and every state in the nation was a compact participant. So we're far away from that happening. And certainly from all states participating. I'm sure you remember my testimony from last year about New York and California. They are probably never going to be compact participants in most professions because they're so big and they can just be self-sufficient. So
We probably should get your testimony. I know you've got some slides.
yeah, so I can walk through it as quickly as possible, and then if people have questions, just to interrupt me. I'm gonna go straight to slide, well, I'll briefly go to slide 3. This is just saying where the recommendations from the working group landed. Some are in H654 and some are in H655. The slide 4 is the short-term recommendation, that's 654, which your committee is well aware of and has passed out of both bodies. Slide 5 is the long-term recommendation. We're really looking toward a tiered telehealth regulation starting in July of 2023. One would be registration with the fee set by Ways and Means on the House side to the lesser of 50% of the renewal fee or the initial application fee. This was a topic of a lot of debate. I'm sure Nolan will talk to you about sort of the fiscal debates that Ways and Means had. But the fee structures are very interesting. There's not a standardized way to do it in the state. And the way that we were applying the fee structure could have odd ramifications for specific license types. So this was the best solution after a lot of discussion in Ways and Means to make sure that we were incentivizing getting registered, balanced with not making it more than the initial application. There is value to either the telehealth registration or the telehealth license. It'll be faster, it'll be more streamlined than a full application. And we think the turnaround time will be significantly faster.
So that slide represents what the Ways and Means Committee
It does.
did. Okay.
It does. So the registration, the fee is the lesser of 50% of the renewal fee or the initial application fee. The term is less than 120 days, not renewable within 3 years, and for less than 10 patients. I will say that there's been a lot of discussion about what a patient means because we have a diverse group of professions. In this is veterinarians. They really want to be part of this bill. And for them, a patient may be a whole farm. So those are things that we would define in rule. And, you know, when you think about therapists, they may have a group therapy that would be depending on what it was, or family therapy. So those are conversations that I've been trying to answer as the bill has been moving, but I really think a lot of those questions will be resolved in rulemaking. The telehealth license is 75% of the renewal fee. The term is 2 years and it's for up to 20 patients. I'll just pause there on the money piece. And I don't want to steal Nolan's thunder. Really, the balancing act here is to make sure that in-state professionals are not paying for the oversight of out-of-state professionals. So we want out-of-state professionals to be contributing to the Board of Medical Practices Special Siloed Fund and OPR Special Siloed Fund by profession or by advisor pool, so that the cost of oversight is not borne by in-state folks. So the fee needs to be something. It should be less than a full license, and that is also the Ways and Means Amendment crediting it. So if you sort of bump up in the tiers, you get credit for what you've already paid. And the working group, and certainly me as a regulator, as the director of OPR, felt strongly that there is importance in oversight of out-of-state professionals who are providing healthcare to Vermonters. There's also importance in the full license, that if somebody has a significant nexus or connection to the state of Vermont, they should hold a full license here. And that's why there's the patient limits. So we're balancing access, ease for the professional with sustaining our programs, not having a financial hit to the in-state providers, and providing appropriate oversight.
So what about the 3-year credit? That, can you explain that? I've just pulled up the language, but was that your idea or did they?
No, that was a Ways and Means idea.
Yeah, this will probably have to go to finance.
Let's do another anyway.
Yeah.
I'm just pulling up the language. Yeah, the fee credit. So you're looking at section D.
Yeah.
So what was the goal of that was that if you have the telehealth registration, you think you're only going to have 7 patients in Vermont. And then you find, you know what, I'm getting referrals from other Vermonters. I should really, and I don't want to refuse them. And I've already paid 50% of the renewal fee. And then if I want to bump up to a telehealth license, that's 75% of the renewal fee. So it would be more costly. So it was to make it so that it was easy for that provider to make the choice to see more Vermonters.
Okay, but it's within 3 years following the effective date of the telehealth. I thought the telehealth licenses were short term.
They are. So the telehealth registration is for 120 days, but you can't get another one until 3 years have passed. Because there's the policy decision from the working group was we want to incentivize people if they're going to continue to have a relationship with Vermont patients, they should get a telehealth license or a full license. Strong preference for a telehealth license or a full license. And so we're trying to get people out of the telehealth registration and into one of those other categories. Okay. So because you can't renew the telehealth registration, we would give you credit for what you've already paid. The 120 days is expiring, or you're getting your 11th patient. Just come and get a telehealth license. We'll give you credit for the $100 you paid for the telehealth registration towards the telehealth license.
Yeah, that totally makes sense. I just don't understand the 3 year. That seems like a long time.
I think it's because they can't renew it for those 3 years. I think that's the rationale.
Okay.
So so that maybe they would want to do the telehealth registration again after the 120 days, but the law would not allow that. So they would need to move to the telehealth license.
Something to think about. Registration.
Yeah, but I was not the proponent of that amendment.
Okay.
I was the responsive party to that amendment.
We're gonna let finance fix this one. Yes.
I'm just trying to see if there's something to fix. It seems a little odd, but I mean, well, I can hear from Ways and Means why they did it that way.
Yeah. I have I'm gonna let you go ahead because we don't want to miss your
Okay.
input. I do have a question. Okay.
So the long-term registration is on slide 6, what we're going to be obtaining. Again, going over the term length and telehealth only, limited to 10. Slide 7 is the telehealth license. Again, going over the basic principles that were in that grid on page 5. The regulatory structure is more outlined in page 8. We will be doing rulemaking around these professions. That is part of the general fund allocation. We're looking at a rulemaking expense of $60,000, just so you're aware with all the volume of programs. The goal is for the application to be abbreviated and administratively less burdensome than our traditional application, although we're always trying to make our traditional application not a burden, but we do want to make sure that someone is appropriately qualified and capable of providing services, whether it's a full license or a telehealth license. So with this program, we'll be looking for verification from one of our sister states or multiple of our sister states, depending on the profession. Particularly with the telehealth license, there will be some requirements around disclosures, public, PHI, and those will be built profession by profession. What needs to be disclosed in one profession wouldn't need to be disclosed in another profession. So
This is also open to juveniles,
yes.
minors. And one of the bills that we passed several years ago was on conversion therapy and not allowing for that in our state. And so if you have, how would that be covered? So suppose you have someone who provides conversion therapy out of state and an adolescent is involved in that kind of counseling.
So yeah, this is
It's dark
something.
curtain over this one.
Yeah, this is something that we talked about in the working group.
You did.
This is something also that I care about very much. So we have built this program to say that someone who's licensed out of state, who's providing care to Vermonters, must follow Vermont's standard of care and statutes and rules, which would include prohibiting conversion therapy. So I would think that we would build that into the disclosures and also into the rules. What is the standard of care? What is required?
So yeah, there would be some indication.
There would be some indication. But also, if we received a complaint about this, then we would prosecute that because they're not meeting Vermont's standard of care, and that's very clear.
Okay.
Yes, I.
It's concerning just because of all the changes that are happening in places like Texas, so.
No, yeah, and Florida too. So,
Sorry,
yeah, no,
it's ridiculous.
Right.
no,
It's a really good point.
It is, and there may be somebody in Vermont who has a perspective that their child should receive
Right.
conversion
They
therapy and
wanna-
seek
they
it
wanna
out.
Find somebody,
Right.
that was my.
Right, so, no, it
Yeah.
is a very live and valid concern, and
Okay.
that is why whoever is doing this needs to meet Vermont standards and would have to attest that they understand Vermont standards and agree to meet
The
Vermont standards.
question is that, I mean, they could lose their ability to practice in our state. But that's a pretty egregious thing to do as a professional, medical professional. But there's nothing that happens to them in their home state.
Well, so I do think that it's possible that right now, we do make complaints with other states. We notify other states of our discipline that we take on licensees who are licensed in multiple states. Many of our professions, all of the medical professions have a data bank, that we report into. So that would be reported in, that state would be notified. Depending on, if it was egregious and willful disregard, I think we would call the state.
Yeah,
But states have different perspectives on this, honestly, so that's a problem as well.
yeah. Okay. There are people in those states who would be happy to find people in this state anyway.
Well, I think that's
Good news, they're good news.
there's good news and bad news, and it goes in each direction. And we did hear quite a bit from the state college system in particular that having telehealth be available for their students during COVID helped their student population, who was more diverse than Vermont, particularly BIPOC and queer students, find appropriate therapists from out of state where there were more selection of diverse
What state was that?
That was in our state. That was our state college
Our
system. I heard from the state college
That's all,
system.
I mean, that's the whole reason, one of the big reasons that we did that, so I'm happy to hear that. there's
It
outcome.
worked.
Yeah,
I have
yeah.
several people from the colleges and who have been emailing me asking me for the status of this bill and for 654, because they have students who are actively seeking out-of-state providers and they don't want to discontinue their care. and I think it's fair to say the state college system, including the independent colleges, all have been relying on COVID flexibilities and want them to continue.
Can we get some of that data?
Sure. I don't have the data of how many students,
No,
but I
I
do have some of the
understand, but
letters.
just
Yeah.
the kind of the qualitative input.
I have a question sort of in the opposite direction. I'm assuming there are other states who are moving in this direction to do licensure and registration for telehealth.
Yes.
Do you have information for Vermont providers who might want to be doing that in other states?
So, not state by state, not profession by profession, but I have been watching trends from other state legislatures. I think Vermont is at the forefront at this moment of really tackling this. But I think other states are coming along. You know, Florida has a telehealth license across all of its professions. Colorado has a similar concept to the registration. What the working group did is we had a subgroup who looked at all state models, and then we essentially, as a working group, crafted the best solution for Vermont out of what's happening in other states. We are answering questions for professionals who are wondering if they can provide telehealth in New Hampshire or in Florida, or in Massachusetts, and we are trying to help people navigate those other states' legislature pages or the equivalent of OPR. But generally, we're sending people to those other states to ask those questions because it is such a rapidly changing area.
Yeah, it's huge. We probably should go ahead so that we can hear from Nolan on the fiscal.
Okay. Well, my last slide is on provisional licenses, and I just wanted to answer Senator Hardy's question of why is this in this bill? And I've talked about this a little bit when we were discussing the nurse licensure compact. Background checks, verifications from other states are the core reasons that our license applications can't be turned around quickly. There was just a story on NPR about nurse licensure times. I was quoted in it. My mom is proud. And you know, we're the fastest in the nation for nurse licensure turnaround times. With fingerprint supported background checks, we're going to become a little slower. We'll still be the fastest, but I think we'll be a little slower. Provisional licenses will allow us to grant the authorization to practice here while we're waiting for those two specific things, or for military members or spouses of military members. So if we are waiting for verification from California, it can take us 6 months to get a verification from California, which is literally a piece of paper saying this person is licensed in California and has an active license. I don't have any power or authority to change that turnaround time. Obviously, the fingerprint supported background checks, we've seen issues with that with childcare workers in the state. It can take time. So what is in our power, or your power really, is to create a provisional license for OPR so that I can give the authorization to practice while we're waiting for these items, and then take away that provisional if something comes back in an expedited way. If something comes back that someone has attested would come back the way we were anticipating, but it didn't. Of course, there are people who are fraudulent, so we want to have a way to revoke it really quickly. But I also don't want to create delay as we're waiting for verification for telehealth licensure or for regular licensure. And this is a may, not a must. So we can deploy it program by program, profession type by profession type. I certainly, I am planning to deploy it in nursing if it passes because of the criminal backgrounds. I don't want to change our nurse licensure times, but I think this is a powerful tool for the telehealth license and registration, where we will start to require verification from another state, but also in our full licensure programs as well.
Okay, thank you. That's been a great intro to the bill. We're going to come back to it, so
Okay.
I'm sure you'll be with us. We look forward to that.
I do too.
Okay. Nolan first. Is this the final fiscal note that you have, or is it?
No,
Oh,
for the record, all 911 not fiscal office, this one that I have is actually the most recent I have, which is with the House Ways and Means Amendment, because it hasn't passed the House. So when it passes the House, all the notes and that's passed the House. So that hasn't been updated. But that said, the things I'll point out haven't changed. So
Okay.
I think that regardless of that fee language or not, it has to go to, will likely go to finance because it's a revenue implication. And what this does is because of this, is an estimated revenue loss of $195,000 over 2 years. And nurse licenses, or these licenses are often a 2-year cycle, so it would be like 77,000 the first year and 120-ish the second year. So it's over a 2-year cycle. Bill also has an appropriation to cover the one-time administrative costs. And OPR has been a strong case for why they would need them to implement this. But those are one-time, mostly one-time. If you go to, I'll just abbreviate. If you go for that piece, if you go to page 3, you'll see the breakout of the administrative costs, and which are one-time and which are ongoing. You'll also see on there the revenue reduction over time from the estimated fee loss. And that's based on an estimate of how many, it's based on what of the licenses that we actually do know about. So this is based on estimates provided by Lauren about who we know, and then there's an estimate of how many people those would stop, how many of those people would get this new license versus the full license. What this bill does not take into consideration is how many people are currently operating without the license as allowed under the current law,
Yeah,
because we have no way of tracking them.
right.
So we don't know how many of those folks are just going to stop practicing, or how many will go ahead and buy a full license, or how many would just buy this license.
We
So
find out.
so we don't know. So this doesn't take that into consideration. So that's the high level.
That's a good high level, because then when it gets finished over in the house, we're gonna wanna see the final product. anyway.
Sure. Okay.
Thank you. Do we have an idea of what we're getting for the 1,000 compact nurses? Before Nolan sat down. I didn't know, that's a Lauren question, it's not a Nolan.
They're all really Lauren questions.
Oh, thank goodness that's not true.
Yes,
Um,
it is.
They are paying the standard nursing fee. The more, the piece that is having a larger impact on our budget is the nurses who are not renewing.
Yeah.
Because
Oh.
so we are actually, we're
Oh.
losing money
Yeah.
through the nurse licensure compact. And we have seen about a third of our nursing population decrease, drop off. So that was something that we talked a lot about when the nurse licensure compact went through. And there is a report coming back to you related to the fiscal impact of,
We need to keep an eye on.
we do.
And have you thought of a creative way to get rid of traveling nurses or keep them in the state?
I'm hoping that you all are thinking of some
We're
creative
working on
solutions
it.
to keep.
We're working on it.
Yeah. I think both healthcare institutions and facilities don't want to use traveling nurses as well. And I don't have creative solutions, although the work of the health reform director and through the getting the name of the report that was published in the early winter, did task the OPR to meet with nurse educators in the state and nurse healthcare facilities to try and figure out creative ways to increase the student populations of our nursing programs. I really think we have a pipeline issue. That's why we have such a reliance on traveling nurses, is we need more nurses who are graduating from our institutions, and then we need to provide incentives to keep them here. So we are working with both the nurse educators and the hospital systems to try and figure out some creative solutions, some of which is already happening, but ways to build on what's already happening and make it more widespread so that capacity, especially in clinical placements, expands.
I just wanted, since you're sitting in the chair again, after, are you, the fiscal note that, are you, I don't know, okay with the fiscal note as it is, that appropriation is,
Did you ask that because no one just left?
yeah.
Um,
Not okay with like
Yeah.
Nolan's math,
No,
but
no,
like.
no,
you know what
I am, you know, we asked for a $1 million allocation with 654, that has been approved by House Appropriations. I'm really hopeful that it'll be approved here in Senate Appropriations. That $1 million allocation is because of lost revenue due to the COVID flexibilities, people not needing a license, and also all of the work that we had to do to stand up and respond to COVID, plus building the short-term registration in 654. This 360 with 655, I do think will cover our costs for starting up the program, and then it's a little bit, I mean, I feel like it's a little bit guesstimate on top of guesstimate for how much revenue we'll get through these programs, but we come back before the legislature, or certainly before the legislature, trying to assess whether or not we should have a fee bill every year. We are a bit constrained because we generally go into the governor's fee bill. If the governor, if he or she chooses not to have a fee bill, that's a little bit trickier for us. But I think I've been testifying, the legislature should anticipate a fee bill from OPR next year. When we had a fee bill in 2019, that was very painful. It was the first year I was director. I said I'm going to do it every 2 years. 2021 was not a good year to bring a fee bill, so I did not try to do that. But I think 2023 will be a fee bill year for OPR. We are running at a deficit. We're running at a deficit of almost $2 million. That is not great. And we are losing professionals both through this telehealth registration, through compacts. So we're really trying to do an assessment of our costs, trying to keep costs down. Our largest costs are our staff salaries, our space, and our IT system. All of those things are really hard to figure out how to mitigate. So working on that.
Yeah, I'm just concerned with the loss of fee revenue in here, and that will exacerbate the situation.
Oh, yeah,
It's a small amount, but it's
vicious
still.
cycle.
It is, and you know, if you are fee-based and you know, I have some professions that I oversee who have not had a fee increase since 2004. So just think about inflation since 2004, the cost of salaries, the cost of IT, the expectations in what we're supposed to do has really shifted since 2004. So I need to do another fee bill, and I need to make sure that we're covering our costs. With telehealth, because we don't know how many people are going to move into a telehealth registration or a telehealth license, we'll certainly lose people. We're anticipating we're going to lose about 25. What we've done is we've looked at the number of our licensees who have a address outside of Vermont. Then we have estimated that we'll lose 25% of those folks because they have a de minimis amount of clients. They have less than 20 clients. So then we've done fee estimations based on that, and we are estimating the losses in Nolan's note. But what we don't know is who we're going to gain. And I think we will gain people because I think the model of healthcare has shifted dramatically because of COVID. Like, it's been on a fast track training, and so I think a lot more people are providing telehealth than did in 2019. So the people who would have come to my office seeking a full license in 2019 probably have not, but will once we start building this regulatory structure.
Right.
Okay, we're good.